All right, well, people are logging in. Welcome, everyone. This is Philip Wong from Emory University. Welcome to our e-lecture series again. Just a little bit of housekeeping before we get started today. So this webinar series is meant for educational purposes only. We've disabled all interactive features for the attendees to ensure optimal quality for everyone. If you guys have questions, you can email us at emorymskradiology@gmail.com. Again, emorymskradiology@gmail.com if you have any questions. We will have a few minutes after the lecture to address any of these questions at the end of the talk. We will be recording this video, and you guys can also watch it at Emory MSK Radiology, our YouTube channel. And so we will post that video later today. Attendees have not been given permission to screen record any of these talks, which may contain material under copyright. Unauthorized recording, use, distribution, and sale of this material without permission from the speaker is illegal. So with that said, Monica, I'll turn it over to you.
Good morning, everybody. Thank you for tuning in today. It's a pleasure to introduce our speaker today, who is John Xerogeanes. A lot of medical students and physicians don't know who John Xerogeanes is because he's known as Dr. X, and that is his name, and everybody knows him like that. X is a professor of orthopedics at Emory University. He is a product of the Emory Medical School. He did his residency in Pittsburgh and his fellowship in sports medicine at the Steadman Hawkins Clinic in Vail, Colorado. X is currently the chief of sports medicine at Emory Orthopedic and Spine Center. And I can go on and on and on about his CV. I'll just summarize a few points. He's been the team physician of almost every college and every professional team in the city of Atlanta. And actually, if you know a college student that had probably an ACL injury and an ACL surgery, most likely X did his surgery. He has, from the beginning of his career in Pittsburgh, he has concentrated on anterior cruciate ligament injuries. He had multiple grants related to several techniques and issues related to the anterior cruciate ligament, and multiple publications also related to ACL. There's no person more knowledgeable about ACL reconstructions than John, and it is a pleasure to have him here. I really thank you. I know he's very, very busy for dedicating an hour to talk to us and enlighten us what's coming on and what's new in the ACL reconstruction arena. Thank you, John.
Monica, thank you for having me. I'm going to share our screen right now, guys. And share, and then do this. Okay. Well, thanks for having me. I've worked closely with the radiology department at Emory for 20 years, and actually worked with Monica's daughter for a long time before I worked with Monica. And now she's following in my footsteps and not Monica's, so I had some influence on her. Today we're going to talk about updates on ACL reconstruction. These are my disclosures. There are some conflicts here in terms of when I show you devices that we have worked on. So I can't talk about this talk without doing that, but I'm not mentioning names or anything. All right, the goals of this lecture are the following. We're going to talk about the ACL and its function, conservative treatment versus bracing, anatomic versus non-anatomic ACL reconstruction, the quad tendon graft, graft selection, and then the anterior lateral ligament. This is a wide-ranging talk, and I think you'll find it interesting. Some of it will be, a review for you, and some of it will be new. So what is the ACL? The ACL is as I tell my patients, is the rubber band that goes between the upper lateral aspect of your femur and the lower aspect, anterior aspect of your tibia. And you guys can see it there with this nice dissection. You guys see it a little differently when you're looking at MRIs, but this is what it looks like. What does it do? It stabilizes the joint. And the most important thing to realize, it controls rotation of the joint, of the knee joint, and translation. So why is that important? Because when this is intact, it prevents injury to the other aspects of your knee, okay? So if you have an ACL that's out and you're running around and you have these instability episodes, you end up tearing your meniscus and ultimately end up having arthritis, and that's what we want to prevent. What about if someone tears an ACL? Do you need surgery? Okay. Well, there's been a bunch of of articles out there that show that if you have an ACL injury and you have instability of the knee and you still do activities that that cause that instability, that you're going to end up having meniscal tears and degenerative changes. Okay. Now, obviously, if you modify your activity and you're older, you may not get these episodes of instability, and thus you won't see the problems with the knee. But most people who have ACL injuries end up being active, and this is the problem you're looking at. So why does conservative treatment fail? If you have a little kid and he tears an ACL and you say, okay, let's hold off, let's not do surgery. Why does it fail? Well, it fails mostly not because of translational instability, but because of rotation, okay? Rotational instability is basically, if it's your right ACL, you're walking, plant your right foot and kind of go to your left. Then your knee pops out of place, okay? I can tell Monica if she has this, hey, don't do A, B, and C, and Monica will do it. But when Monica's daughter is an athlete and a tennis player, and she's 18 years old or 16 years old, and I tell her or her son, hey, don't do this, they're going to keep doing those activities. So they don't listen to us, and thus activity modification doesn't work. Do you lose rotational control with every ACL injury? And the answer to that is no. It depends on the morphology of the tear. Sometimes what will happen is part of the ACL will tear and part doesn't. And the part that controls more rotation doesn't fail. And thus the people have some rotational control left. So they may have a partial injury and have partial function. While that may not work for an athlete, it'll work for someone, you know, from a lot of us in the room who aren't doing cutting sports anymore. Okay. So when you're looking at an MRI, you got to look at the tear and you see different variations. And that's why it's important to look sagittally and coronally, because sometimes the ACL will be healed to the PCL. You'll have normal translation and abnormal rotation. Sometimes it'll be partially healed to the wall or partially torn, and you can get an abnormal exam, but not grossly abnormal. So how do you determine this? I talk to the patient. I get, you know, I have an MRI, but this is what you guys don't get. This is where you're at a disadvantage. So radiologists, you can look and you can see them, but you don't get to move the knee, and at least not yet. And you don't get to see this here. This is called a pivot shift. Now watch the knee. If I bend the knee up and down, you'll see it pop out of place, pop back in, pop out of place, pop back in. That's rotational instability of a knee. And you have to do an exam to feel that, okay? That's called the pivot shift. And that also is what produces the lateral bone bruise that you all see when you get a sagittal view on an MRI. Okay, so if you see this here, that you guys know that's an ACL injury, okay? That's not an MCL, little difference, not a dislocated patella. I teach my medical students and residencies, when you get this, the first, you're starting lateral, you see this, you got to be worried about an ACL, okay? Does this ever happen with the graft intact? And yeah, it can, okay? Especially in little kids, you can see this where they're lax and they can get this injury, and they may have a viscoelastic injury to the ligament, and you really got to worry about this. When you all see this with a reconstructed knee, so if they have a reconstructed knee and you see a bone bruise pattern on a new injury, that graft isn't working. That's the problem. You're not going to be able to, that person's not going to be able to do all right. You're going to need to revise that ligament. So either it's stretched or put in the wrong place. most of the time when you see this, you're going to see a vertical graft. So you'll see the tunnel being more posterior here, and the tunnel on the femur being more anterior. So the graft is more straight up and down. Do braces work? When we put people in braces, they work pretty good for translation, but they don't control rotation, okay? And they're expensive. Now, if I sold braces in our practice, and you know, the braces are cheap to make, but they're expensive when they sell them. You make, you know, $1,000, $1,500 per brace. You'd make a lot of money. I do 300 ACLs a year. You do the math, you'd add up a lot of money, okay? But the bottom line is they don't really work. This is level 10 evidence, but you never hear football player tore his ACL, he'll wear a brace and we'll fix him at the end of the season. Look in the paper. You're going to hear football player tore ACL, he'll have surgery, he'll be back next year. So that's really good evidence that they don't work on ACL deficient knees. There are two types of ACL reconstructions. Now this is really important because you all could see this when you're looking at X-rays or MRIs. There's non-anatomic, and those were usually done before 2005 at Emory, 2010 in most places. And there where you make a tibial tunnel, drill through the tibial tunnel into the femur. So you're going to see a direct, on a coronal view, you're going to see a straight line between tibial tunnel and femoral tunnel. You can draw a line on it. Those are non-anatomic ACLs. An anatomic ACL means I'm going to put a drill hole into the tibial footprint and then one in the femoral footprint, and they look different, okay? So all ACL reconstructions aren't the same. If you do a non-anatomic reconstruction or put your tunnels in the wrong place, you're not going to have a normal functioning ACL. Transtibials were done for about 25 years, and they were the most utilized technique all over the world because it was easy and reproducible. This is what you see. So this one's easy because you use metal screws to hold the graft in place. But look how that's a straight line. When you see that, you're going to say, okay, that's an ACL reconstruction. But if that's also the graft you're going to see, and then you're going to see do an MRI with the graft intact, and you'll see a bone bruise on the new injury, meaning that this graft doesn't control rotation. That's the problem with the non-anatomic reconstruction. The pros of that are they're easy. It's easy to do, it's easy to teach, and it's reproducible. The problem is it doesn't work right, okay? Again, people don't do well with a normal Lockman and abnormal pivot shift. Their ACLs are going to fail. How about the outcomes? When you looked at the outcomes of ACL reconstructions done with this type of reconstruction, and you look at all these things, people will tell you, oh, they do great, okay? But look at this number here. 70% return to previous levels of play, okay? 92% had a pivot shift or did not have a pivot shift. That means 30% did not return to their right level, okay? They didn't return. And 8% had a pivot shift, and we know you can't play well with the pivot shift. So these really aren't really good results, and our thought process in the early 2000s is we could do better. So how? Well, we started doing anatomic reconstructions. This is kind of a cool group of slides I have that are interesting. I think you'll like. I call it like Surgical Anatomy 101. So there's that picture again, and you see the ACL. The interesting thing is the ACL is made up of two bundles, and you can tear these bundles independently. With our 3T MRI and the beautiful cuts that we get, and for those who are training here, you have no idea how spoiled you are because we have the best techs in the world. Our techs are awesome. And you come to UWash, you get a perfect MRI, and you can see this. It's beautiful. You go outside the system, not so much. But if you look at the average length of an ACL, it's about 2.5 centimeters long. It's not huge, okay? This is a guy who unfortunately, Paul, passed away, but he was an anatomist, and he did these beautiful dissections. He would spend days dissecting these knees, and these are beautiful pictures of his where you can see the ACL and what it looks like. And you notice it's not straight up and down. It's going from right around the insertion of the lateral meniscus and then to the posterior aspect of the femur, posterior distal. These are 3T MRI, CT scans. I just called Monica yesterday and asked her about Osiris if we had a license anymore, but it's free. And Osirix is a great thing to get CT scans. You take the DICOM images and you can make these cuts. Okay, so you can see where the ACL actually is. It's very posterior on the femur, the knee's at 90 degrees. Okay, when I'm going to show you where people put the tunnels. When you, in this one here, you see the same picture of the knee at 90 degrees. This is a transtibial reconstruction. It's completely outside of the anatomic footprint. This is an anatomic reconstruction. It blows out right exactly the holes where the footprint where the ACL was. So you can see why the transtibial is an anatomic, non-anatomic operation and didn't work perfectly. Okay. When we did a bunch of research and a lot of kinematics, and when you do an anatomic ACL, you get more normal kinematics. So less force is taken up by the joint and more force is taken up by the ACL. So thus, you have less chance of getting a chondral injury, meniscal injury, and less arthritis. But here's the thing: this person you fixed tore their normal ACL, and now you're putting one back in that's going to absorb the same amount of forces. So now the issue is: are we going to see an increased ACL re-injury rate when we do it anatomically versus transtibial? Because the transtibial is not really doing everything that the ACL does. So the joint's taking up some of that extra force. So that's what we worry about. Now, we've been doing this about 15 years, and our reconstruction, our rates of injury look about the same. And I'll get into that a little bit later, but it's something we always worry about, okay? When you fix an ACL, you have to take a graft from somewhere else, okay? So there's two big groups. There's grafts from you called autografts, in which you can use a patella tendon, a hamstring tendon, or a quad tendon, and then various allografts, okay? Allografts are just grafts from dead tissues, and there's different types of tissues you can use, okay? What about a hamstring? This was a really popular graft in the 95 to 2010 range, okay? You'll see these incisions on the patient's knee, these two types, and basically you harvest both of the hamstrings from down there, down distally. You pull them out, you make the new ACL from that. Now, what's the problem with this? Well, the problem with these is that you can't predict the size radiologically of a hamstring. So we know if you get greater than 8 millimeters diameter, they fail, okay, at a much greater rate. So there's all these things of wadding them up and making a thicker graft. The problem is you guys will see you'll see absorption of bone in these tunnels, and you'll see MRIs and CTs with these big holes there. So that's a little bit of an issue. There's multiple ways to fix these grafts, and you don't want, on X-ray, you'll see all these different types of things. You'll see screws, you'll see cross pins. All these things look differently, but you can usually see these things on. You can always see these things on X-ray. With our new MRIs, it's not as big a problem. But I hate metal screws in anything. These plastic or bioabsorbable screws are great, except they don't really bioabsorb. They form mush, and they're problems on a secondary surgery. This is that issue with tissue widening, okay, where you'll see the tunnel widening rather. And this is a big problem. We don't see this as much with the other grafts. How about patella tendon grafts? Well, that's the big incision you'll see on the front of someone's knee. You can do it through a smaller incision, but it's hard. You basically take two bone plugs and a piece of the middle third of the patella tendon, and you put these in place with either buttons, as you can see right here, cross pins, or screws. We tend to favor the left side of the screen because there's nothing in the tunnels except bone. That heals beautifully, and you have two little pieces of metal on the outside. What are the issues? Frontal knee pain, patella fracture, and re-rupture of the patella tendon. All those things are big problems, okay? What about allografts? Allografts are great for old people, not for young people. If you're over 30, we have about a 4.5% reoperation rate in 1,500 patients that we looked at. Look at that, remember that number, 4.5%. When you're 20 years old and younger, 20% failure rate. So we don't do these in athletes, we don't do these in younger people when we're talking about the ACL. Something like an MPFL or an MCL, you can think about it because it's outside the joint, or on a multi-leg when you don't have other options. Why does allografts fail? Well, they're irradiated, they're frozen. There's a bunch of, they're putting hydrogen peroxide to all this stuff to cleanse them. So there's different reasons why they can fail, or maybe they just don't incorporate. Maybe there is some sort of rejection, although we've never shown that. Also, they're easier to do. So you have surgeons that don't do very many of these. I do 300 a year. If an average surgeon who does, quote, sports medicine does 20 or less. So when you think of that, if you're doing 10 of something a year or 15, you're probably not as good at it as the guy who does 100 a year, and you're probably going to not be good at harvesting the graft. You want to get done faster, you're going to use an allograft in the wrong person. But then there's also non-compliance. If any of you have a teenage daughter, they're going to do what they want to do, or a son. And then these guys on the left, well, they're going to do whatever they want to do too. So you got to make sure you look at your patient, and an allograft doesn't hurt as much. So there's a lot of chance for people to be non-compliant because they either don't listen to you because they don't hurt, or they think they're ready to go because they don't hurt. So when do we use an allograft? Again, multi-legs, non-athletic, and greater than 30. Now, quad tendon is a newer option, okay? This is something that we started looking at in about 2012. It's been done in the past, but it's something I really got interested in about 2012. And basically, we took this from the biomechanics and histologic level all the way to doing the surgery and developing techniques. And what we're talking about is taking a chunk of the middle third of the quad tendon. And it's a big, big piece of tissue, okay? Because that quad tendon is a massive piece, you know, two times the volume of your patella tendon. So it's a big piece of tissue. As I said, it's not a new idea. People were toying with it, but no one perfected it and told people how to do it. And the reason why people didn't jump on board is they didn't understand the anatomy, the histology, all this stuff. Now, it is really important when you start your career and you're looking at stuff and you have a question, sometimes you got to go back and just do it all over again. And we knew this was going to be a big process, but that's what we did. We've done about between 1,300 and 1,400 of these now. We took a team of people and we looked at all this stuff, and this is what we came up with. First thing we did a systematic review. And we went and did all the literature. Sarah Sloan, who runs sports at MUSC, was my fellow at the time. And he's a master at systematic reviews right now. And we published this in Arthroscopy, but it gave us, we knew all the literature after doing this. And it was a really important starting place. The quad tendon has a very complex anatomy. And if you dissect it or even look at MRIs and you follow it up, the proximal portion of the tendon has a whole bunch of different variations, so it's confusing. You know, you have your vastus intermedius level, then you got your lateralis and medialis coming into the sides, and then you have your rectus femoris. All these tendons blend together to form the distal 3 centimeters of the quad tendon, which is a beautiful dense tendon. But then you start getting more proximal and you get variations in the anatomy. So I kind of think of it as two parts. You get a multi-layer part and a distal part. Now, we started in the lab by just cutting up cadavers. And this is what a quad tendon looks like. You see the VMO on the right side of the screen and the lateralis on the left. But interestingly, if you take away the muscle, look at on the right, there's tons more tendon. So this is a massive tendon. It's not just what you see when you're looking on the outside. Now, obviously, who could see this the best? Well, you guys, right? You do ultrasound, you can do MRIs, except we don't go that high on a normal scan. So what we had to do is twist some arms, kind of do stuff that we probably shouldn't have done. And when we did, we did this on the MRI. So you can see a lateral view of the knee. I made my fellow cut this in half so I didn't cut my fingers off. And that's what you can see. And then we looked at this portion, okay? And you can see again, this one stays intact till about 3, then it starts getting multiple layers, and then multiple layers more defined after 6 centimeters. If we look at the histology, there's more collagen per cross-sectional area in a quad tendon than a patella tendon. If we look at biomechanics, we went in the lab again, and Monica's daughter did this study, and we pulled a bunch of these things apart. And what we found is that the ultimate load of the a native ACL is very similar to a quad tendon graft, 10 millimeter quad tendon graft, and much greater than a 10 millimeter patella tendon graft. The modulus, which looks at the tissue quality, is much more similar to a native ACL with a quad tendon than a patella tendon. Now, that's really interesting stuff because remember, the patella tendon is kind of considered at that time the gold standard graft. If you harvest a 10 millimeter piece of patella tendon and a 10 millimeter piece of quad tendon, okay, when you harvest the quad tendon and remove it and test the residual, it is the post-harvest strength of that, the residual, what's left is 2,400 newtons. The intact patella tendon is 2,000 newtons. So what it tells me is I'm not going to get, that's why you don't see quad tendon ruptures after harvesting like you do with the patella tendon, because it's a much bigger, stronger tendon. Predictability. And this is a cool study we did in our lab at Georgia Tech where we used 3D MRI technology. We published, this is one of my most cited publications in AJSM in 2013. These are 3D MRI views of the patella tendon that thanks to the guys here we were able to get. And then you see what we did, this nice 3D reconstruction here. And what we found out is we figured out the length, the average width, and the thickness of the tendon. And what we found out with that is that we can always get a 7 centimeter tendon on anyone over 5 feet. And that's measured by the tip of the muscle on the left side to the patella. But if I needed more length, I can always just, reflect the tendon, and it goes, and you see more tendon proximally. Okay, this is really important because the thickness of this is consistent. And it's 1 point at up to 6 to 7 centimeters, and we want a 7 centimeter graft. The volume of this is huge because it's 1.8 times as thick as the patella tendon. Okay, so what do we do with this information? We compare it to the gold standard. The volume of the graft. The quad tendon is this much volume. The patella tendon means you have this much tendon and you have this much bone. Very important here, because if you take a 10 millimeter width graft that's 3 centimeters long, because that's the amount in the joint, you basically are going to have, the difference is going to be the thickness of that graft. So you're going to get 88% more intra-articular volume of graft. That's why we like this graft, because it's better tissue, more collagen per cross-sectional area, and remember, biomechanically, it's more like a native ACL. What about little kids? Well, we went and we did ultrasound of a bunch of little kids, and we found that the average length or the average thickness of a little kid, 6-year-old, is 3.2 millimeters thick. And when you think about it, what's the average thickness of an adult? Your patella tendon is 3.2 millimeters. So even in little kids, we have enough tendon to do a reconstruction and have the same size that you would have in a patella tendon of an adult, the same thickness. Okay, that's vital because you can't use a patella tendon on kids because it'll stunt their growth plate. The harvest time, what does it take me to do it in the OR? This is 22 minutes for a patella, 13 minutes for a hamstring, and 8 minutes, which is now probably down to 6 minutes of a quad. So it's a very fast harvest and saves you time. When you look at morbidity, the quad has almost no morbidity compared to the patella tendon, which gets all those things, and hamstrings, which if you've had one, you will talk about the numbness and hamstring weakness. So it's much less morbidity. Cosmesis, for any of you that have had ACL surgery, this is beautiful. We can do it through a little tiny incision, either horizontally, what we used to do, and now we do it, or vertically is what we used to do. Now we do it horizontally because it's incision is even better. Now, this is a pro basketball player who went and she had this in college at Auburn. And then we came in and did this. Now, she's not doing pro basketball anymore. She's doing modeling stuff. This is a problem, guys. This is ugly. This is pretty. If you can do that and have equal results or better results, that's great. This is how we get it. We make a little incision, and we have this little tube harvester that we have, and we just sit there and push it up, and it cores out a section of the graft. Then we pull it out. We pull it through the graft, and you'll see this here. Pull it on top, and then we have this little plunger thing we put in. And when it comes out, there's your graft. So it's a nice graft ready to use. All right, that's what it looks like after we fix it. And I know you guys, I'm talking a little bit of surgery now, but I want to give you context to what you're going to see on the MRIs. Take a look at this. These are the buttons that hold it in place. And how these basically work, they're like toggle bolts. We pull them, we drill a tunnel like that's about the diameter of this graft, and then we pop through the cortex with a little 4 millimeter hole that this can fit through longitudinally. So we can pull this thing up, this pops out the top, it toggles and then catches on the cortex, and then this is a shortening suture here, and we pull this up into the tunnel, okay? So that's what it looks like. We have the length of this thing, that's what your tunnel looks like here. So this is where your graft will be. This little thing is where the button will go. The button will flip out here, and then we'll tighten it up. And that's what it looks like when it goes in. You can see how the button flips through here. And then we tighten it up, and on the bottom we do the same thing. Now this is to show you what a tightening suture is like. So there's another button that you'll see distally, and we just pull this thing, and that tightens it, and now that pulls the rest of the graft into the tunnel, and that's what it is. So it's like a Chinese finger trap is how the guy who invented this thought of it. And that's exactly what happens with the sutures. It's just like those finger traps you play with. And this is what it looks like when it's done. The graft is in the tunnel, and you have a button on top and a button on the bottom. Now, we've done about 1,300, and part of this and the fun of this is to look at the outcomes of how your people did. Now, I'm not going to go too much into this, but I just want, when we talk about this, it's very important. We have the largest series with the youngest group, and it's important to have a young group because they're the athletes. You can do a lot of these on old people like me or half the guys over 30 in the room. You're not going to re-injure yourself as much as the younger people, okay? And male-female ratio is almost equal. Our graft failure rate is 4.2%, all comers. Okay, that is just like that number I showed you. Remember 4.5%? Just like the numbers with the patella tendon. Here's the interesting thing. Look what happens if you took females between 15 and 20 versus males. 8.3%. Okay, people over 20 years old, 2.8%. So our high school females and college females are the people we're scared about. They have the big injury rate, 5 times higher than their twin brother. And originally, and thus they also have a re-injury rate, and we don't know why, okay? How about revisions? When we do revisions, we looked at our first 100 revisions. Again, everything looks, everything, the age distribution, the sex distribution is about the same. And some of these were second and third revisions. And again, what we found is that, I don't have that slide, our re-injury rate was right under 5%, so very similar. So it's a good graph for a primary and also revision. These are studies that looked at quad tendon grafts historically, and they're very equal to patella tendon grafts, and they're better than hamstring grafts. Okay, so my thoughts on the grafts are basically allografts are good for revision, multiple ligament reconstruction, patients out of college. Quad tendons are good for any age, but they're great for the younger, big athletes. Patella tendons are good for revision surgeries and also non-compliant patients because they hurt, okay? So you want the one that hurts the most. We've done a lot of pain research. It's that one. Hamstrings are a good alternative in larger patients, but there's something that really, I haven't done one in about 8 years. We're just not doing them much anymore because we don't need to. Now we're going to talk a little bit about the ALL. Now, the anterior lateral ligament. Now, this is interesting because everyone talks about it, and the only reason people talk about it is because the New York Times wrote a paper on it, okay? And this is your typical doctors identify a new knee ligament, okay? Now, we got a lot of radiologists in the room, and you guys are basically anatomists. And I'm a knee surgeon, so I think I'm a knee anatomist. And you tell me how we're all going to miss this new ligament that the New York Times said some brilliant guy came up with and we missed, okay? And that's what it's supposed to look like, okay? Well, all of us could look at an MRI and we can find the popliteus, we can find the LCL, and most of us now, especially the MSK people, are going to find the popliteofibular ligament, and that's a tough one to find. Okay, but now let's see, what about this ALL that we all are, somehow are missed? You'll see them dissect it and say, here it is. But I can dissect a lot of stuff in the knee and take a capsule and then remove capsule on both sides and say, hey, here's a ligament. Okay. So how do we all miss this? Are we all like this little baby? Well, I'm not sure we really did miss anything. Remember way back when in the 70s and when they started talking about ACL, Jack Houston started talking about anterior lateral rotary instability, which is the pivot shift. And he said, something's wrong on the outside of the knee. So let's reconstruct something on the outside of the knee. Now, they did that, but what they didn't understand, it was really the ACL that was controlling that and the lateral meniscus that had control. So they came up with all these operations that worked on the outside of the knee, and they just didn't work very well. Okay, if you know people that had ACLs in the 80s, they all have arthritis and they never really got back to play, and they all have total knees right now. Okay, so they were thinking about it back then, but did they miss this ligament too? Well, actually, Erica Umpierrez did this study and basically pulled a whole bunch of MRIs on my patients who tore an ACL. So we had acute MRIs on first-time ACL people. All those ACLs were performed by me. And then what we did is we had 3 MSK radiologists independently look and see if they could, one, identify the ALL, and then when we did that, we realized that in our pre-studies that most of the time we couldn't. So it's okay, let's take an area where the ALL is and see if we'll grade the capsular edema. And if we had a big amount of capsular edema, we should see more failures in those ACL reconstructions because we're not addressing the ALL than those that didn't have capsular edema. So what we found from this study is basically no one could definitively identify the ALL on multiple cuts or planes on the MRIs. None of us could. I couldn't, Walt couldn't. I'm not sure who else was involved in that study. Adam may have been. Adam, I'm not sure if you were a fellow then. I'm not sure. But anyway, we couldn't do it, okay? We could identify it and grade the edema, but we found no correlation between the edema and the ACL surgical failure, okay? So now what do we do with that? There's a whole operation for doing ALLs, and one of the reasons why is because we have people that have failed once or twice, and we know that maybe doing a non-anatomic extra-articular operation could help those people, okay? Because we want to control that rotation. But an interesting thing, when we look at we had the ALL operation, when we studied it biomechanically, no difference between pre-surgery, no positive clinical outcome when you do it, okay? So now, we're kind of going back to what did they do way back when, and they did a lateral IT band tenodesis where they take a strip of the IT band, go under the LCL, and then hook it in just behind the lateral epicondyle. And that controls, at least initially, rotation better. My gut is it all stretches out. Are we doing that last thing? Yeah, we're doing some of that now, but just because we don't have an answer for your teenage daughter who's had 2 ACLs and now we have to do a third one, okay? There's something biomechanically, the shape of the bone, or just biomechanically different that predispose those people, and maybe this next thing will work. But you're going to hear that, you're going to see that scar, and you'll see buttons and things on the lateral side of the knee, and you'll try to determine what they're for, and a lot of times that is what they're for. So the points of the lecture, that's what we did. I think we hit most of those points. During COVID, you have to do, my kids decided to adopt a dog, and it turned out to be a very big dog. So 6, 7 months, 8 months into this, I have a 120-pound dog that wants only to sit in the front seat of my Jeep, and he's still growing. And you haven't heard him today, which is amazing because he's usually fighting with my other dogs. Well, that's the talk, guys. I'm gonna stop sharing the screen, and then if there's any questions, you guys can write in, and then I'm happy to answer them if Adam reads them to me.
Thank you, X. Really appreciate it. Excellent talk. Adam has some questions. He's just monitoring the email, so he will take over right now.
Thank you so much. That was an excellent talk. I really enjoyed it. I had the pleasure of, as a fellow, going in, seeing X in the OR in action, and it was a great experience. And to all the trainees out there, if you haven't had the opportunity to see someone do some of these surgeries, it's very helpful and insightful. So in that, a couple of questions. You know, I look at a lot of the operative reports, and I've noticed, you know, most of the surgeons, and you in particular, are very meticulous about documenting what you do. And typically it seems as though you drill the tunnels within a range. You know, I see usually between 8, 10. I haven't seen a whole lot above 10. So I guess my question to you is, in the setting of a recurrent injury where the graft fails and you're trying to assess tunnel diameter for osteolysis, above what threshold do you use to say, you know, this is something that I'm going to have to stage?
So that's a great question. We figure out the size on a primary by the size of the graft we have, and you measure the footprint. So everyone's different on the size of their footprint. So if you have a little girl and she has a little footprint, you can't put an 11 millimeter graft. On average, you're wanting something between 8 and 9 and 8 and 9.5. And those 9 will probably fit in almost every person, and 8 as you get smaller. When you have osteolysis and you see a lot of it on either plain X-ray or the MRI, then you have to worry, especially if it's in the area that you're going to put your graft. So if it's a transtibial and it's posterior on the tibia and it's superior on the femur, a lot of times I don't worry about it because I can drill a small hole anatomically, let's say a 4 or 5 millimeter tunnel, and then I dilate up these 5 millimeter sequential dilators that instead of removing bone, it pushes that bone into the area of osteolysis. And then I can put a nice graft where it almost like in virgin bone. Now, if it's in the same area and I'm seeing something that looks like greater than 10 millimeters of osteolysis, a lot of times I will get a CT scan and do 3D recons and look at it, okay? Or I will tell the person, look, I'm going to go in there, and if it's greater than 11 millimeters, I'm going to curette it all out, bone graft it, and stage it, okay? So it's just like a hole in a wall. You're going to put spackle in and come back and do it again. But that's kind of that when you're more than 11, you got to worry, especially if it's in the right location, or you have, you guys see bio screws in that area, then you're going to worry about that.
Okay. And a couple follow-up questions to that. So the first question is, have you noticed any associations with tunnel osteolysis, and in particular, any types of hardware interference screws? And the subsequent follow-up to that is, I've noticed that you and several other surgeons have sort of moved away from interference screws, and I see a lot more tibial post screws and tight ropes. Is there a reason to not use interference screws?
That's a great question. So if I used a metal interference screw, then when I'm doing a revision, and again, if you're not doing a lot of revisions, you don't worry about this. You either you can't drill through it, so you have to remove it. And now I got a big hole in the bone, okay? Because that big screw, nothing grew in there. So we've all kind of gone away. Plus things go wrong when you use interference screws. You can cut the graft, you can break the plug. So it's easier to use a tie over post, and they work just as well. The companies used to, all talk about pull out strength, and you get some better pull out strength if you use an interference screw and bone, but we don't have failures when we use tie over a post. It's cheap, so people don't like to talk about it. The pull out strength is lower, but we don't have early failures with ACLs. You have late failures, so it's a non-issue. Secondly, the bioabsorbable screws, when you put those in there, everyone says, oh, you can't see them, and you can drill through them, so they're less of a problem when you're doing a revision. The problem is they never, I don't care what histology these guys show you, they don't turn into bone. They turn into mush. So you have basically like an area of osteolysis. So if you used a big interference screw or 2 of them, now you go in there and you correct that stuff out because you can't leave it there. It's dead mush. Now you got a huge hole. So that's why almost everyone at Emory, there may be a few guys that, you know, that are in the out, community members or a department that don't, but all the guys inside are pretty much staying away from that when we can.
Got it. Another question that just came in, a lot of the time we see increased signal at the anterior root of the lateral meniscus as it comes towards the tibial footprint. And there's a tendency, I think, to wonder, is there a tear there or not? And I know this is a well-known pitfall. I guess my question to you, from your experience in the setting of ACLs, and then just in all comers, if you're taking them in for scope, how often do you see tears at the anterior root of the lateral meniscus?
So with ACLs, almost never. Okay. Now, so what happens is if you look at the posterior aspect, anterior root of the lateral meniscus is the division. If you come medially across the knee, is the division between the posterior lateral and the anterior medial bundles of the ACL. So it's acutely involved. And sometimes when you tear the ACL, you get into that part of the footprint. It almost looks like it's part of the lateral meniscus, but when you get in there, it's really not. And it's kind of just medial to where the intermeniscal ligament, if it's a profound one, comes off. Now, where I do see the anterior horn lateral meniscal tears are usually in older people, especially females in valgus. And you guys are excellent at calling it. And it almost looks like a ghost. Like you see the lateral meniscus and it just doesn't look right. And a lot of times it's just much less dense on our PD fat sats. It's not black. It's a little lighter. And sometimes you on the axials, and that's another thing. Our MRIs are so beautiful because you can see that almost always on our axial cuts. We get perfect cuts. And it doesn't look right. Those are real. And those people, you ask them, these ladies come in, no one wants, they said there's really nothing they can do for me, but they have pain when you hyperextend them. That's an anterior horn lateral meniscal tear. And it's a quick little surgery and those people love you. So yeah, you do see it in that setting, but very rare with an ACL.
That's anterior horn or root?
Like the anterior root horn of the lateral meniscus. So right where it inserts and coming back, not posteriorly, but anteriorly.
Gotcha. A couple other questions. How often do you see chronic knee pain after ACL reconstructions?
It depends what the other damage is in the knee and how old the patient is and what graft you do. You see much more frontal knee pain on patella tendons. Doing a quad tendon, if there's no other damage in the knee and the patient is in good condition, it's pretty rare. If you're a female and you're in your 40s or over, you're smaller, bone density issue, sometimes drilling that tibial tunnel will give you anterior medial knee pain. And the hardware, when we do a post, one of the reasons we like a button is that it doesn't pinch on the hamstrings and you don't get as much pain with it. Interference screws could give pain. So when we do a button, it works pretty nicely because it's less painful. But I would say it's if you look at our IKDC, somewhere about 8% of the people will have some sort of residual discomfort in some part of their knee after an ACL reconstruction.
And the follow-up question to that is, do you see techniques like COOLIEF playing a role in managing chronic pain after an ACL repair or reconstruction?
It'll be interesting. I think I haven't seen enough of my people come back. Usually we're using COOLIEF on more degenerative or people that have these weird, joint line pains. I've had some come back, and I would say my gestalt right now is it's working. Okay, I have people come back and say, hey, I feel better. Now, obviously we need some controlled trials and we need longer follow-up because I'm not sure how long it lasts. But if you have joint line pain, I think it's our pain, even in the front of your knee. I think it's helpful, but we don't have enough yet for us to me tell you definitively. But I'm excited about it, and our problem is not. Our problem is we need more people doing it so we can get patients in, and hopefully the insurance companies will buy into it.
All right, we just had another one come in. What is your take on primary ACL repairs instead of reconstructions and the biologically enhanced healing augmentations, either with repairs or reconstructions?
Great question. So primary repairs work pretty well if they're acute and peel off lesions, like on PCLs, you guys will call it, looks like a peel off lesion, or looks like it's when it's torn and sitting right next to the bone, there's not a lot of soft tissue between stuck on the bone. You can go and put sutures in and repair those. Now, people have really pushed the envelope for mid-substance and others, and only one guy has shown good results with that. He's a guy out of New York who we were residents together, so I've been friends with him a long time. But no one's really been able to reproduce his, and he doesn't do huge numbers, okay? I think the total number of these he has done over the last 5 or 6 years is probably, less than 200. So he doesn't have huge numbers of these, okay? But it's something that is interesting. Again, they had that one in the paper in USA Today about this sponge with growth factors that they're doing at Children's Hospital. They haven't done very many. I'm not sure it works. There's some of my partners may go into the clinical trial on that. I'm not going to do that because I'm not going to put a kid or anyone and say, I'm going to try this on you, and I'm not really sure it's going to work, and waste a year of your time. An athlete's not going to do that. Okay. I just don't think they work on true mid-substance tears. None of the biology is going to reconstruct that ligament under tension. You got to be careful because they do all this stuff on partial tears, and a lot of partial tears are going to be functioning pretty well anyway, especially if if the rotational part's intact, what we talked about at the beginning of the lecture. So I think you got to be really careful with that stuff. It's hopeful someday it's going to get there, but it's not there yet.
All right. Well, that was the last question we had today. We really appreciate you taking the time, Dr. X. And
anytime. It was fun, guys.
Yeah, awesome talk. Thank you so much.
All right. Nice seeing everyone, and thanks for having me.
All right. Stay safe, everyone.